Welcome to our lecture on the pharmacological management of cardiac arrest. Today, we will explore the specific vasopressors, antiarrhythmic agents, and adjunctive medications used during resuscitation efforts to optimize patient outcomes. Let's start with vasopressors. The primary goal of using a vasopressor during cardiac arrest is to optimize cardiac output and blood pressure. The standard vasopressor used in these scenarios is epinephrine. The recommended dose is 1 milligram, administered via intravenous or intraosseous access, repeated every 3 to 5 minutes. What happens if you cannot establish IV or IO access quickly? In those cases, epinephrine can be administered directly into the endotracheal tube. The dose is higher here, 2 to 2.5 milligrams, diluted in 5 to 10 milliliters of sterile water or normal saline. However, keep in mind that the ET route results in highly variable and unpredictable drug absorption. Interestingly, while epinephrine has been a staple in resuscitation for years, the clinical evidence is nuanced. Studies show it definitely improves the rates of return of spontaneous circulation, or ROSC, and hospital admissions. However, there is a lack of large studies proving it improves long-term survival to hospital discharge or neurological outcomes. Because of this, the American Heart Association does not recommend routine use of high-dose or escalating doses of epinephrine. So, how does epinephrine actually work during a code? It acts by stimulating adrenergic receptors. This produces significant vasoconstriction, which in turn increases blood pressure and heart rate. Most importantly, during cardiac arrest, this vasoconstriction shunts blood to the core, improving the critical perfusion pressure needed to deliver oxygen to the brain and the heart. When administering epinephrine peripherally, technique matters. After pushing the 1 milligram dose, you must follow it immediately with a 20 milliliter flush of IV fluid. Then, elevate the extremity above the level of the patient's heart for 10 to 20 seconds. This ensures the drug is rapidly pushed into the central circulation, where it can actually do its job. Moving on to antiarrhythmic agents. Similar to vasopressors, there is a lack of definitive research showing that routine antiarrhythmic administration improves long-term survival to hospital discharge. However, amiodarone has been shown to increase short-term survival to hospital admission when compared to a placebo or lidocaine. Amiodarone is considered for the treatment of ventricular fibrillation or pulseless ventricular tachycardia that remains unresponsive after shock delivery, CPR, and a vasopressor. It is a highly complex drug. It works by affecting sodium, potassium, and calcium channels in the heart, and it also possesses both alpha and beta adrenergic blocking properties. During a cardiac arrest, the initial dose of amiodarone is a 300 milligram IV or IO push. If the patient remains in VF or pulseless VT after this initial intervention, you can consider giving a second, smaller dose of 150 milligrams in 3 to 5 minutes. What if amiodarone isn't available? Lidocaine is a long-standing alternative, though it has no proven short or long-term efficacy in cardiac arrest. The initial dose is 1 to 1.5 milligrams per kilogram, IV or IO. You can repeat this at half the dose every 5 to 10 minutes, up to a maximum of 3 milligrams per kilogram. If you only have an ET tube, the dose is 2 to 4 milligrams per kilogram. Next, let's discuss magnesium sulfate. Intravenous magnesium is specifically used to terminate or prevent recurrent torsades to points, especially in patients who show a prolonged QT interval during normal sinus rhythm. Remember, for pulseless VT, immediate high-energy shock is the primary treatment. Magnesium is merely an adjunctive agent used alongside defibrillation. When torsades de pointes is present, give a loading dose of 1 to 2 grams of magnesium sulfate IV or IO, diluted in 10 milliliters of fluid and administered over 5 to 20 minutes. It is also highly indicated for patients with known or suspected low serum magnesium. Always check the patient's history for conditions like alcoholism or severe malnutrition, which strongly suggest a reversible electrolyte abnormality. Now, let's look at the use of steroids. For in-hospital cardiac arrest, or IHCA, steroids are not recommended as a routine standalone treatment. However, randomized controlled trials have shown success using a specific bundle. This bundle combines intra-arrest methylprednisolone, vasopressin, and epinephrine, followed by hydrocortisone after ROSC if shock is present. This specific combination has significantly improved survival to discharge with good neurologic outcomes. The data for out-of-hospital cardiac arrest, or OHCA, tells a different story. In these settings, steroids were studied as a sole treatment rather than a bundle. Dexamethasone showed no improvement in ROSC or survival. While one observational study linked hydrocortisone to improved ROSC, it showed no actual benefit for survival to discharge. Therefore, for OHCA patients, the use of steroids during CPR remains of uncertain benefit. To wrap up, remember that epinephrine is your primary vasopressor to optimize perfusion, given at 1 milligram every 3 to 5 minutes. Amiodarone is your first-line antiarrhythmic for refractory VF or pulseless VT, with lidocaine as a backup. Magnesium is reserved specifically for torsades de pointes or hypomagnesemia, and steroids show benefit only when used as a specific bundle during in-hospital cardiac arrests.